Okay, guys. So we are starting the image-based discussion of pathology here. So this I'll focus on some of the important images that they ask in exam. So based on some facts, some image, they will give you a theoretical question as well. So first, understand this. In this image, you can see like this concept is called as autophagy. So autophagy, understand this. You will see the formation of autophagosomes. There are two mechanisms. One is called autophagy, and second is your ubiquitin proteasome degradation. So understand this. In autophagy and proteasome degradation, you will see these are two mechanisms that are responsible for causing atrophy. So atrophy is done by two things, that is autophagy, either by a concept of autophagy means there will be formation of autophagosomes, right? And ultimately what they'll do, they will lead to phagocytosis of the cells. So understand this. Then next will be, there will be a formation of a complex with a protein. That protein is called as ubiquitin. So understand this. This proteasome degradation will occur because of a protein. So here you have to remember two facts: autophagy and proteasome degradation that can cause atrophy, and atrophy can also occur because of interaction of this protein called as ubiquitin. So understand this. A new update which I will tell you that atrophy is also considered a pre-malignancy now. It is also now a pre-malignant, especially in endometrial cancer. So previously, like we say, atrophy is not considered pre-malignant, but remember now it is considered pre-malignant condition. So if I move forward and into this diagram, so you can see we have a normal cells. Normal cells, you will see there will be injury to the particular cells. That injury initially is reversible injury. If this injury persists or progress, we call this irreversible injury. And there are two variants of irreversible injury. One is called as necrosis, and second will be apoptosis. The principal difference between these two factors, you should understand this. In apoptosis, there is no damage to cell membrane. So cell membrane is absolutely intact. And in apoptosis, remember, there is no inflammation. So these are the main difference. So we are doing a revision session. So just I will talk about the main things which they ask repeatedly in exam. So apoptosis, remember, there is no damage to cell membrane and there is no inflammation. Okay, if I move forward, understand this. So there are many factors, like it could be trauma, it could be nutritional imbalance, it could be some genetic abnormalities, it could be some immunological disorders or autoimmune disease or immunodeficiency disease. It could be infections like COVID infections or any other bacterial infection. It could be toxins or any kind of biochemical abnormality. It will ultimately affect your structural changes. It will cause structural changes in the cells, and that will alter the molecular, functional, and morphological abnormalities in cells. So what we develop certain signs and symptoms. So you understand this. Ultimately, what you are seeing are multiple causes of a cell injury. Now understand this. When you see a normal cells, you will see normal cells. You will see it can have reversible cell injury. So in reversible cell injury, you will notice a fact that here you will see swelling. So the hallmark feature you will see here will be a cell swelling, right? So that there will be membrane swelling. There will be swelling of endoplasmic reticulum. So ultimately, understand this. What you will see, you will notice there will be formation of myelin figure. These myelin figures are made up of phospholipids. These are made up of phospholipids. You can see this enlargement here. These enlargements are called as blebs. These are blebs, right? If this injury persists means now it will convert into irreversible. Now it will convert into irreversible. So that is what we call this. We call this irreversible cell injury. In irreversible, you will see the classical picture that you will find amorphous density in the mitochondria. Okay, let me tell you few more difference between necrosis and apoptosis. So by the way, the difference with the normal classes as well. So you know all these difference. So understand this. The main difference you should remember is there is no inflammation in apoptosis, right? There is no inflammation and there is intact plasma membrane. Right? In necrosis, you will see a nuclear change, that is pycnosis. Pycnosis means there will be a shrinking of cell. So there will be a shell. Karyorectus means there will be fragmentation. That nucleus will have fragmentation. And karyolysis means there will be dissolution of nucleus. So you will see shrinking of nucleus, fragmentation of nucleus. Nucleus will fragment. There will be fragment parts of nucleus. So these are the changes that you see in necrosis and apoptosis. Now understand this. Whenever there is a cell injury, there are two important factors. There are two important factors for a cell injury. The first factor that you should remember is for a cell injury, the first factor will be type of injury. So let me highlight this here. The two important thing will be a type of injury. Means what is the type of injury and duration of injury. And duration of injury. So two important things that you should understand for a cell injury will be a type of injury or duration of that particular injury. Okay, if I move forward, so I can show you some of the images. For example, just see this image. In this, you can see initially this is your normal. So this will be your normal kidney slide. So this is the normal kidney slide, right? So understand this. You will compare. If you will compare this here with, you can see there is a cell swelling. You can see the cell swelling with formation of blebs. You will see the bleb formation and cell swelling. And ultimately, so here you will see this injury is considered reversible. And ultimately, you will notice here, you will see a fragmentation of nucleus. You will see the fragmentation of nucleus, and you will notice there will be leakage of cell content. There will be leakage of cell content. So this is your necrosis injury. This is your necrosis, and necrosis is considered irreversible. Necrosis is considered irreversible. Okay, then I'm having a typical wedge shape infarct. A typical wedge shape infarct. This typical wedge shape infarct you will see in coagulative necrosis. So this is classically seen in coagulative necrosis. Extra point if I say this is the main necrosis and this is the answer when you don't know the answer. So this is the principal necrosis, or I can say this is your main necrosis. So जब exam में answer नहीं पता है, whenever you are not on the answer, you are confused, choose this answer. This is the safest choice because all other necrosis, this is the main necrosis, or you should use the word parent necrosis. Parent necrosis means ये सारे necrosis का बाप है. It is the main necrosis. All other necrosis are derived from this necrosis. And this is, remember, this is classically seen in heart. It is seen in almost all organ. But remember a fact that this type you will never see in brain. This is never seen in brain. Because in the brain you will find a liquefactive necrosis, that is also called as a colligated necrosis. Liquefactive or a colligated necrosis. So in the brain you will find a liquefactive or colligated necrosis. So just if I ask you the question like coagulative necrosis, you will see in different organs. For example, you can see this where, you can see this in heart, you can see this in spleen, you can see this in kidney. So you can answer, you can pick almost all organ, you will find this type of necrosis, but you will never find this type of necrosis where? In the brain. In the brain. Right. So in this drawing, I can show you the two areas. So compare this here. To understand this, this is like an area you will see here, this area which is represented by the alphabet N. So this is your normal area. This is your normal area. So normal area, right? So where you are seeing nothing. But if you compare this, you will see the outlines are preserved. But if you compare this with this area, that is here, you will see necrotic debris, subnecrotic surface. This area will be infarcted area. This is your infarct area, right? So understand this. So here you will see, you can see the nucleus here everywhere. You can see the nucleus on this surface, but there is no nucleus. There is a disappearance of nucleus. There is no nucleus, or you can see the disappearance of nucleus. That is called as Skelolysis. So this is again your Skelolysis. So means this is a necrosis. So this will be your necrosis. You will see Skelolysis, right? But you will notice the outer, from outside it look normal. Outside you can see it look normal. Outer periphery is normal. This is a classical coagulative necrosis. Okay, moving ahead, you will see this type of necrosis. We call this liquefactive necrosis. So this is, you can see the infarct of the brain with this, the pus. We call this a liquefactive necrosis. Liquefactive necrosis. The other name for this will be colligative necrosis. Colligative necrosis or liquefactive necrosis. This is classically seen in your brain. Other place you will see this. You can see this in abscess. You can see this in abscess. You can see this in parenchyma of pancreas. In parenchyma of pancreas. So remember this. Sometimes they ask a question by twisting the question that which type of necrosis we will see in pituitary, in putamen, in cerebellum. So all answer will be same. That is just liquefactive. So remember, in pancreas, we have a parenchyma, means inside the pancreas or surrounding the pancreas. Surrounding the pancreas, we have peripancreatic fatty layer. So in that area, you will find a fat necrosis. In that area, you will find a fat necrosis. Okay, compared to this, you can see here, you can see this a chalky white-like material. So you can see this is what we call this. We call this a yellow white or cream color. Yellow white or cream color, a cheese-like material. So it looks like a paneer, it looks like a cheese. This type of necrosis, we call this gaseous necrosis. You will see this, we call this gaseous necrosis. Moving ahead, if you see the necrosis, you will see here. You can see here, again, you will see a chalky white deposit. You will see this whitish deposit in the yellow background. This is, classically, you will see this yellow fat material along with this white calcium. So you will see a fat material plus you will see calcium. This type of necrosis, we call this a fat necrosis. Fat necrosis. So understand this. In this fat necrosis, understand this. You will see a calcium soap formation. This process is called as saponification. So this process, when you see fat will merge with calcium, we call this saponification. Saponification. This type of necrosis, let me show you once again. We call it necrosis. Okay, now understand. So let me show you once again. You will see normal cells. After the normal cells, what you will notice? There will be condensation of chromatin and then blephation. Ultimately, you will see there will be fermentation of a cell and this formation of bodies. Formation of and this it can occur in angiogenesis, right? Angiogenesis, it can occur from Okay, so am I audible, guys? Fine. So understand this. So it was an unstable network. So let me restart this again. So you can see these cells in the edges. These cells are dying. These cells are dying. So understand this. Initially, these cells are joined like this. So now these cells are dying. So we are not getting this. We call this a webbed finger or webbing of finger. Webbing of finger. Pathological example, you have to remember just one example that is important that they ask an exam. That is sometime in acute viral hepatitis, you will see a body. That body is called as Councilman body. And this Councilman body is nothing, it is apoptotic body that is seen there, that is seen in acute viral hepatitis. Acute viral hepatitis. So pay attention, it is not seen in chronic hepatitis, it is not seen in alcoholic hepatitis, it is seen in acute viral hepatitis. Then understand this, then there are different pathways of apoptosis. Just I am showing this image because sooner or later they'll just try to ask this image based question. To understand this, we have extrinsic pathway, also called as mitochondrial pathway. So here understand this, you should remember this extrinsic pathway is activated by, we have intrinsic pathway or mitochondrial pathway and we have extrinsic pathway. So if I say extrinsic pathway is activated by FAS and trail ligand. FAS and trail ligand means trail stand for TNF alpha related apoptosis inducing ligand. Ultimately, they will form FAD that will activate your caspases. And ultimately, it will lead to activation of other enzyme, breakdown of cytoskeleton, and you will see the changes in the cell. This extrinsic pathway is activated by cytochrome C. So that is what you have to remember. So if I say extrinsic pathway activated by FAS and trail ligand and it will stimulate caspases. Intrinsic pathway is stimulated by cytochrome C and this will stimulate caspases. The most important enzyme in apoptosis will become caspases. This will be caspases. Ultimately, this caspases will stimulate other enzyme like for degrading protein we need protease. For degrading nucleus, we need endonuclease. For lipids, we need lipase. Okay, next, understand this. You can see this image. You can see this is the body which I was talking about. So you can see this body. You can see this body. This body we call this Councilman bodies or apoptotic body. So this is, you can see this body in the slide. So you can see the apoptotic cells. So this is the body which I was talking about. We call this apoptotic body. or apoptotic cell. We can use the word apoptotic body or apoptotic cells, right? And understand this, we have different type of reactive oxygen. So I am taking this image-based discussion so that you can solve some theoretical MCQ as well from these images. So all these images are from the standard textbook of problems. See, if I see, so we can have hypoxia. Hypoxia will lead to decrease in ATP. There can be formation of a reactive oxygen species. Reactive oxygen species, ultimately what will do, they'll cause the cell damage, right? So this is, you should understand this. The most common cause will be hypoxia or ischemia. This type of necrosis you will see the pink, bright pink color. This is a classical necrosis. We call this fibroid necrosis, and this is you are seeing in a vessels. So this is a classical fibrinoid necrosis. Fibrinoid necrosis in polyarthritis nodosa in PAN. Fibrinoid necrosis in polyarthritis nodosa or PAN. Okay, moving ahead, understand this. Whenever there is ischemia, there is damage to mitochondria. So remember my statement, earliest organelle that is affected in cell injury, that will be mitochondria. There will be decrease in oxidative phosphorylation. So there will be mitochondria as it produces ATP. So now ATP production will be decreased. So there will be less ATP. Whenever there is a less ATP, you will see the sodium pump activity will decrease. Sodium pump activity will decrease. You will see there is more influx of calcium and water. So calcium and water will go inside. So you will see when water is going inside, it will lead to endoplasmic reticulum swelling, cell swelling, and the formation of blebs. And simultaneously, you will see because of ATP, less ATP, there will be initiation of anaerobic process, that is glycolysis. And because of glycolysis, you will see there can be formation of lactate, and that case you will see the pH will be decreased. You will see there will be detachment of ribosomes, so there will be decrease in protein synthesis. So in this point, just I want to highlight this thing. There can be formation of a lot of free radicals, or we call them reactive oxygen species. For now, you have to remember the most dangerous free radical is this one, your hydroxyl free radical. This is your most dangerous free radical. So these are the images which you don't have to study. Just remember the statement which I am writing, or just write down the notes which I am writing. Other figure I thought to discuss because it will be more discussion so that you can get more images and some theoretical MCQs. So understand this. So most dangerous free radical will be the same, your hydroxyl free radical. Okay, then there are certain conditions that can occur due to different factors. So for example, there can be disease that can occur by mutant proteins. For example, cystic fibrosis. So remember that is due to CFTR gene, and this is due to a chromosome 7 defect. It's a chloride channel defect, right? So you will see there will be defect in chloride transport. So basically the main organ that is affected here will be your lungs. So mainly lungs, remember lungs and pancreas are primarily affected. Nowadays we are having a new drug for treating this condition. So remember previously we were using N-acetylcysteine. N-acetylcysteine, the same drug that we are using for paracetamol toxicity. But now we have one more drug to treat this condition that is called as Ivacaftor. Okay, then familial hypercholesterolemia means it is due to an LDL receptor mutation. Takes us disease, a biochemistry question that they ask in exam. It is due to hexosaminidase B. Hexosaminidase B deficiency. Right? Then we have disease that can occur due to misfolded proteins like retinitis pigmentosa due to rhodopsin mutation. We can have Creutzfeldt-Jakob disease. It's a prion disease due to prion protein, PRPSC. There can be Alzheimer disease, that is due to accumulation of amyloid peptide. Then we can have alpha-1 antitrypsin deficiency due to, that is anti-elastase, which protect your liver and lungs. So there will be death of hepatocytes, and there will be pan-acinar emphysema. In case of alpha-1 antitrypsin deficiency. Right? Okay, moving ahead. If I say the mechanism is slightly changed, so let me make clear. There's a decrease in oxygen supply, so there can be toxins, there can be radiation. So ultimately, mitochondria are the first which are damaged. When mitochondria are damaged, ATP generation is reduced. There's production of reactive oxygen species. You will see multiple cell abnormality will be seen, and that is classically seen in necrosis. Right? You will see there is a disbalance of pro and anti-apoptotic gene. For just I'm saying, if I say the pro-apoptotic gene, the most important gene will be your P53, and anti-apoptotic gene, the most important gene will be your BCL2. So there will be a disbalance in these two proteins or genes, so that there will be leakage of these proteins, and ultimately you will see the apoptosis. Now in this diagram, you can see a normal myocyte. Compared to this, you will see body is having an adaptation tendency. That adaptation tendency, you will see there will be hypertrophy of myocytes. This hypertrophy is classically seen in patient who is having hypertension for many years. So remember, sustained hypertension for many years can lead to left ventricular hypertrophy or right ventricular hypertrophy. If you see the histological slide, you will see there will be hypertrophy of the myocardium and myocardial cells. If you see this, compare this, you can see there will be a normal brain cell. This is a normal brain cell, normal person, for example, brain of your or for brain of me. Of mine. So you can see this, compare with this another cell. That is, you can see in this cell, you will see there will be a this sulci and gyri change. You can see first thing is here, you will see there is a change in sulci and gyri, right? Next thing you will see here, you will notice here is there is an atrophy of a cell. You will see the atrophy of cells. So understand this. This is a classical change you will see in a patient who is having Alzheimer's disease. These are the changes in a brain, or an elderly person, for example, 80 or 90 years. So in that case, you will see certain changes in the brain. So what changes you can see? You can see there is atrophy. You can see the atrophy here. If I notice, so this is an Alzheimer's disease or an elderly person, right? So you will notice here, you will notice like with age, you will see there will be atrophy of the brain. So there will be atrophy of cells, right? So we call this age-related atrophy. And you will notice the blood supply of the brain will be reduced. When blood supply of the brain will be reduced, then what you will notice there will be narrowing of gyri, and widening of sulci. And these are classical change. Brain atrophy, narrow gyri, and widening of sulci. And sometimes you will see hydrocephalus ex vicu. These are classical change you will see in a patient who is having Alzheimer's disease. Okay, let me move to the next image. That is, you can see a normal basement membrane and columnar epithelia is replaced by squamous epithelia. You can see this change. Normal epithelia, ultimately this is replaced by squamous epithelia. This is the classical change. We call this metaplasia. And when columnar is replaced by squamous, this is most common metaplasia, and this is classically seen in smoker's lung. It is classically seen in smoker's lung, right? In Barrett, you will see just reverse. In Barrett esophagus, you will see squamous will be replaced by columnar epithelia. In Barrett, you will see squamous will be replaced by columnar epithelia. That columnar epithelia will be intestinal type of columnar epithelia. Okay, let me move ahead. You can see sometimes you will see normal cells, and you can see normal cells. Sometimes there will be infiltration by fat. There will be infiltration by fat. So we call this a fatty liver. So this infiltration can occur. Fat can deposit in your liver. We call this fatty liver. Fat can accumulate in your vessels. We call this atherosclerosis. Fat can accumulate in the skin. We call this xanthoma. You can see there can be a protein mutation. So there can be an accumulation of abnormal proteins that you can see in many diseases. Like, for example, fatty liver, we use the term steatosis. And this is protein mutation. You can see where in Alzheimer's disease. You can see this protein, this misfollowed protein. You can see in prion disease. These are mutated protein defect. Sometimes, so some disease can occur whenever there is a lack of enzymes. So these can occur in lysosomal storage disease. If I say sometime you will see there is indigestion of indigestible material, so there can be accumulation of some exogenous materials. So this exogenous material, it could be pigment, it could be anything. So in this slide, I can show you some of the pigments. So you can see this image. So you can see this. This is, you can see in the liver, the stain is called H&E stain, hematoxylin and eosin stain, right? This is, you can see a golden brown granular appearance. You can see these granules. You can see a golden brown granular appearance. So we call this a golden brown granular appearance, right? And here you can see this is the normal in the H&E. That is the most common stain that we use. And if you see this under this stain, it's a blue color stain. This blue color stain, we call this Prussian blue. So this is a Prussian blue stain. It is a Prussian blue stain. So understand this. What you will notice these both images which I am telling in front of you. That is, these are, you can see a golden brown color in hematoxylin and eosin stain with a granular pattern, and Prussian blue stain. You will see the bluishness, right? This is a pigment called as hemosiderin. This is due to the pigment that is hemosiderin, and these are nothing. These are iron deposits. Hemosiderin is iron containing pigment. So it will have two pattern, a fine granular golden brown pattern, or you can see a bluish pattern that is in a special stain. Special stain that we use for hemosiderin will be Prussian blue. Prussian blue. We also call this a pearl stain. The other name will be pearl stain. Pearl stain. Right. Okay, then understand this. I just want to tell you that is there can be everybody want to be young forever. So what is the protein that can cause delay in aging? So that protein is your protein that help to fight us with aging. That is a protein called as, anyone try to answer which protein? Which protein? Try to answer. I told you this. Just think of this. Ubiquitin is another. There I told you ubiquitin. Ubiquitin, what it do? Ubiquitin will do what? Ubiquitin is taking part in atrophy. It causes atrophy, right? If I say the protein, you will see the protein that is responsible to fight against the aging process. That protein name I am asking you. Anyone try to answer? Sirtuins. It is sirtuins. Sirtuins. Now understand this. The best way to delay aging will be calorie restriction. So best way to delay the aging process, that is your calorie restriction. Other things you don't have to study. Sometimes some people will look prematurely aged. For example, they look much older than their normal age. This is we call this a premature aging or Werner syndrome. We can see premature aging or Werner syndrome. We also call this progeria. Okay, then we have hypertrophy. You can see hypertrophy of muscles. So hypertrophy you will see in many conditions. So I am just writing the example of hypertrophy. So you will see hypertrophy in the breast. You can see the hypertrophy in the uterus during pregnancy. You can see the hypertrophy in your heart. We call this left ventricular hypertrophy or right ventricular hypertrophy. So these are the examples of hypertrophy. Okay, then if I say the hyperplasia also you can see in many organs. So this is like a common condition that is called a benign prostate hyperplasia. So you will see the symptoms like patient will develop. The mnemonic is hyphen, hesitancy, incontinence, frequency, fullness, bladder, urgency, and nocturia. So if I ask you for BPH, it is an hyperplasia, but remember, it is always benign. It will not convert into cancer. It is exclusively benign hyperplasia. If I say for treatment, we give a drug that is finasteride. Just your pharmacology recap: finasteride will act by inhibiting an enzyme 5-alpha reductase. Right. Sometimes the patient for symptomatic relief, what we give a drug called as tamsulosin. So finasteride and tamsulosin, these are the drugs that we can give. Lastly, you can see here hemorrhagic infarction of your testicles. You can see this is the dry gangrene. Again, you can see the white chalky cheese-like material. You can see we call this a gaseous necrosis. So this is the revision, that image-based revision. So let me move more things. You can see this is a fat necrosis, and you can see the pink fibroid necrosis. Remember, it will look pink in color, and it is classically seen in polyarteritis nodosa. You can see this in rheumatic fever. In rheumatic fever, they will form a body. That body is called as ash of bodies. And again, you can see here, this is your apoptotic bodies. Right. Apoptotic bodies. Okay, let me move to the other part of discussion. You can see we can have a normal cells. So whenever there is a change in the pressure, you can get formation of an exudate and a transudate. So here by this slide, just I want to tell you the difference between exudate and transudate. Transudate is something that is having low things. Low means low protein, low cells. So remember, transudate means low protein, low cells. It look like a water. Exudate means it will have high protein and it will have high number of cells. So remember, exudate, it is like your pus. Right? Transudate is like a watery secretion. So this is the difference between transudate and exudate. So remember, more protein, more cells, even more specific gravity you will see here in exudate. Right. Okay, with this slide, just I want to tell you the difference between different type of cells. So I told you like we are having two type of inflammation, acute and chronic. So like acute inflammation, you will see the onset will be fast. Mainly the cells you will find neutrophils, right? You will see mild and self-limited condition. But you will see the local signs are prominent. Means local signs of inflammation, like there will be redness, there will be pain. These are 5 cardinal signs which I told you. There will be pain, there will be redness, right? There will be a swelling, right? There will be loss of function, right? So these signs will be prominent, and in chronic you will see the onset is slow. Main cells will be your macrophage. The main cells, remember, it will be macrophage. In some viral infection like COVID-19, it could be lymphocytes. Some autoimmune disease also, it can be lymphocytes. Right? So understand this. There is less fibrosis in acute, but there is more fibrosis in case of chronic. So remember, in chronic inflammation, just I want to add one line. You will see in chronic inflammation, you will see more but slow tissue degeneration. You will see more but slow tissue degeneration with fibrosis and scarring. With fibrosis and scarring. Okay, then with this step, I just want to add few things. Like I told you, in acute inflammation, how the process occurs. You will see initially there will be a process called as margination, so which is not given in this Robbins image. So just I am highlighting this. The first thing you will see will be margination. After margination, you will see there will be rolling. So number 2 will be rolling. Rolling is done with the help of selectants, right? Then you will see adhesions. Right? There will be adhesions. So step number 3 will be adhesion. Then you will see there will be migration throughout endothelium. That is, you will see there will be cells will come out. We call this a transmigration. Right? Then there will be chemotaxis, right? There will be opsonization, and ultimately there will be phagocytosis. So these are the steps that you'll see. The question they ask in exam is, which are the different types of selectants? We have L-selectin, P-selectin, E-selectins, EPL. So remember, these are 3 types of selectants. Selectants can be E-selectin, P-selectin, L-selectins. Right? If I say the integrins, understand this integrins. What integrins? So integrins are helping in adhesion. So what integrins will do? They will take the help of some molecules, like they'll take the help of LFA1 and MSE1. So this information is not important for FMG exam. Those who are preparing for PG, they can study this. For FMG, it's not important. For FMG, remember, it is only integrins that is affecting your adhesions. Okay, then if I can show you, like you can see the nature of leukocyte infiltrate. So these are the changes you will see. You will see initially the neutrophilic infiltrate. So here you will see neutrophilic infiltrate. The first cell that comes in any inflammation, the first cell will be neutrophils, right? And later you will see later on, after that you will see a mononuclear cell infiltrate. This N is neutrophil. So just let me write this. N is neutrophil. Later on, you will see a mononuclear cell infiltrate. Later on, you will notice a mononuclear cell infiltrate. Okay, then we have different type of transmitters. So just let me highlight the important point. If I say histamine, the main source will be mast cells. Prostaglandin, it can be from mast cells. If I say the leukotrienes from mast cells and leukocytes, so we have different cytokines like TNF, IL-1, IL-6. So nowadays they are important. Why? Because these IL-1 and IL-6, we do that testing. We do this testing for COVID-19 patient as well. Then we have platelet activating factor. It causes vasodilation and increased permeability. And then we have some complement pathway and kinin pathway. Now you can see this image. So we have discussed this in the understand this. We have discussed this in the class as well. So you can see arachidonic acid. Arachidonic acid will undergo its degradation into 2 pathways. That is a COX pathway, we call the cyclooxygenase pathway, and a LOX pathway or lipoxygenase pathway. With COX pathway, what you will see? With COX pathway, you will see prostaglandin, you will see prostacyclin, that is PGI2, and you will see thromboxane A2. With LOX pathway, you will get leukotrienes, and you will see lipoxin. So leukotrienes, understand this, it can be A4, C4, D4. If you remember this leukotriene C4, D4, E4, they call bronchospasm, so they are called as SARSA. So these three, they are called as SARSA, means short reacting substance of anaphylaxis. Short reacting substance of anaphylaxis. Leukotrienes B4 will help in chemotaxis. It will help in chemotaxis. Okay, moving ahead. So these are the action of different type of icosanoids. So just I want to add is putting like vasoconstriction. Remember, vasoconstriction is done by thromboxane A2. Thromboxane A2 will do vasoconstriction, right? If I say the cytokines and inflammation, so these are the cytokines, understand their role. TNF. This will stimulate expression of endothelial adhesions molecules. IL-1 is having a good role in fever. So this question already came in exam. IL-1 antagonist, the drug we use is anakinra. IL-6, it's an acute phase reactant. If I say about IL-17, it will lead to recruitment of neutrophils. It will cause recruitment of neutrophils. In chronic, you will see IL-12 action. IL-12, what it will do? Nothing. It will increase the production of interferon gamma, and interferon gamma will further activate the macrophage, and it will help in formation of granuloma. So it is having a classical role in development of granuloma. IL-17, the same role. You will see the common will be IL-17 in both acute and chronic inflammation. Right? In chronic and acute both inflammation, you will see the same thing. Okay, just next understand this. These are the three pathways. So we can have a classical complement pathway, which is due to IgG and IgM. You can see an alternate complement pathway, and you can see a mannose binding lectin pathway. So these are three pathways which are called as complement pathway. Ultimately, you will see there will be, by any pathway, you will see there will be deposition of C3 in the microbe. The C3 will deposit, and ultimately you will see the development of MAC. MAC is your C5B29. So just I want to add this. MAC is C5B29. This is your membrane attack complex. It will attack the membrane, and it will lead to lysis of cell. So this type of inflammation you will see in a cross section. We call this a serous inflammation. You will see there is accumulation of serous fluid. We call this a serous inflammation. Okay, moving to this, you can see in the pericardium, you will see deposition of fibrin. You can see the fibrin-rich material deposition. We call this a fibrinous pericarditis, right? And here you can see these fibrin-like. You can see these lines. These lines you can see, right? So you can see these lines, right? So these are what you can see. These are a classical histology of fibrinous pericarditis. If you see here, you can see these abscess. These are small draining abscess. You can see small draining abscess, right? And if you see this abscess, you can see here, these abscess may have cellular debris, and there will be congestion of blood vessels. So this is an example of your purulent. This is how a purulent inflammation will look like. Moving to the next one, you can see here, this is a chronic duodenal ulcer, right? And if you notice, you can see the ulcer bed. You can see this is a duodenal ulcer, crater of that duodenal ulcer. This is a classical example of a duodenal ulcer. And these changes I have already discussed. In chronic inflammation, what are the changes you will see to understand this? So these are the changes. The question they ask in a theoretical MCQ as an all accept question. Remember, angiogenesis, new vessel formation, mononuclear cell infiltrate, and fibrosis. These are feature of chronic. In acute, you will see in acute what you will see, neutrophilic infiltration. So these are the changes. That is vascular changes, right? That is 4 vascular changes you will see. First will be a transient vasoconstriction, vasodilation. These changes I'm writing. Transient vasoconstriction, vasodilation, increased permeability, and stasis. You will see neutrophil recruitment, and you will see some mediators. Question they ask in exam is all our changes you will see in acute inflammation except, and all our changes you will see in chronic inflammation except. Right. So understand this. You can see this is the image where you will see a chronic inflammation. So you can see the chronic inflammation in this image. So just try to understand this. If I notice this, you can see in chronic inflammation, especially in a lung, for example, chronic inflammation can occur due to chronic tuberculosis or chronic any kind of inflammation. So you can see initially you will see collection of chronic inflammatory cells. So you can see these are inflammatory cells, collection of cells. right? So these will be your inflammatory cells, right? So you can see this is inflammation. You will see chronic inflammation with inflammatory cells, right? If I compare this, you will see the changes in acute inflammation. You will see the changes. You will see here. This will be your acute inflammation. The changes you will notice here will be acute inflammation. So how the point is how well you can differentiate acute or chronic. So understand this. In chronic, in acute, you will notice there will be neutrophils that is filling your entire alveolar space and blood vessels. So neutrophils will fill. Here you will see neutrophils are less. Here you will see neutrophils are less, right? But you will notice there will be some cuboidal epithelial cells that can lead to fibrosis. So there is less. This is a chronic inflammation. Chronic inflammation. Okay, then understand this. Try to understand this. You can see hematopoiesis, as you know, it can occur in yolk sac first, and then it can go to liver and bone marrow. Ultimately, hematopoietic stem cells. You can see blood monocytes. It can activate your macrophage. Right? So macrophage will have different names in different organs. For example, in Kupffer cells, these are macrophages of your liver. Alveolar macrophages are macrophages of lung. Microglia cells, these are macrophages where? These are macrophages in your brain. So let me move ahead. If I show you, you can see the stages. This is initially you will see monocyte. Initially you will see monocytes. This monocytes will convert into macrophages. So monocytes are the cells that will, these are precursor of macrophage. So monocytes are ultimately converting into macrophage. So this we have already discussed, classical complement pathway and alternate complement pathway and alternate. Now understand this. You can see here the inflammation. This is an inflammation, right? And here you can see numerous. These are numerous eosinophils. So this is an inflammation with a lot of eosinophils. Inflammation with a lot of eosinophils. Okay, then understand this. In this, you will see the center area will be having necrotic material, right? This central area will be having necrotic material, and this is a classical necrosis that we call this gaseous necrosis. This is, you will see tuberculosis. This is seen in tuberculosis. You will see the necrosis will be in the center of this. I'll show you another image where it will be more clear. Okay, then understand this. Tuberculosis, you know already, it's caused by Mycobacterium tuberculosis. So you will see caseating granuloma here. One more thing, if I say tuberculosis, you will see the special cells, giant cells. These giant cells are called as Langerhans giant cells. In TB, you will find a Langerhans giant cell. Leprosy. Leprosy, understand this. Leprosy is caused by Mycobacterium leprae. Leprosy is caused by Mycobacterium leprae. Right? So here also you will find acid phase bacilli, but here you will find a non-caseating granuloma. Generally in TB only you get a caseating granuloma. Syphilis, especially in the tertiary syphilis stage, you will see gumma formation. That gumma is granuloma. Cat scratch disease. Cat scratch disease, it is caused, this cat scratch disease, understand this. Here you will find stellate granuloma. Stellate granuloma. In sarcoidosis, you will see again a non-caseating granuloma. Inflammatory bowel disease, there are two in number, like Crohn's disease and ulcerative colitis. In Crohn's disease only, you will find granuloma. In Crohn's disease, you will find granuloma. Okay, let me move ahead. You can see this normal cell. There is a mild injury, right? Mild injury, there can possibility of regeneration, but injury is severe, then you will see there will be formation of scar. So these are two things that is telling you about how the body is having tissue repair. This is that body can have tissue repair by two things. So it can repair by regeneration, or it can repair by scar formation. It can repair by scar formation. Okay, if I say, you can see there are certain stages. These are the steps of scar formation. So if I say these are the steps of scar formation, so understand this. If I say these are the steps, that you should understand this. The first step, if I say the step number 1, which is in front of you, you will see there is a fibroblast, macrophage, neutrophil, and capillary. You can see this stage. You will see here you will see the platelet will accumulate, so platelet will form platelet plug. So first stage will be a platelet plug, right? Then you will see in second stage, you will see this platelet plug will also have a proliferation of epithelial tissues, so or granulation tissue. So you will see there will be proliferation of epithelial tissue and granulation tissue. So what you will see, you will develop an S-char. This is S-char is due to formation of granulation tissue. Just I'm writing GT means granulation tissue. And ultimately you will see that is a scar. You will see ultimately that is a scar. We call this a fibrous scar. So understand this, there are three stages. First you will see a platelet plug, then you will see a granulation tissue, and then you will notice a fibrous scar formation. Fibrous scar formation. Fibrous scar formation. Now understand this, sometimes tissue repair is also done by a process called as angiogenesis. Angiogenesis means there is formation of new blood vessels. There is formation of angiogenesis. Remember the question that there is a theoretical question, that is angiogenesis, the main factor is your VEGF, vascular endothelial growth factor. Vascular endothelial growth factor. So you will see there will be a recruitment of pericytes. There will be recruitment of pericytes, and you will notice that is there will be elongation of this vascular streak. So there will be formation of new vessels. This way, a new vessel is formed. What you need to remember, that is the factor that is helping here is vascular endothelial growth factor. Vascular endothelial growth factor. Right. So understand this. If I say this is, you can see a lot of granulation tissue. You can see a lot of granulation tissue. Here you will see a lot of granulation tissue. So just I'm writing, you can see the granulation tissue. And along with this, you will notice a lot of blood vessels, that angiogenesis, and you will see some edema. You will see some edema. So these all are features suggesting that is this is inflammation that is now having a healing phase or chronic phase. Now understand this, if you see this with a trichrome stain, right? So understand this, in this a trichrome stain, you can see a lot of collagen matrix. You can see trichrome stain, collagen matrix. How to remember this? So understand this, chroma means color. So if I write the spelling of collagen like this, color, you will see trichrome stain. Okay, moving ahead. So understand this. Now I will show you some of the features of chronic inflammation. So understand this, in the image 1, you can see the external appearance. These are basically your skin ulcers, right? So the first ulcer which is in front of you, this is your venous ulcer. You can see this is a venous ulcer. This will be your venous ulcer. If I say, you can see that this image, this will be your arterial ulcer. This will be arterial ulcer, right? So understand this, you will see this will have a more extensive, arterial ulcer will have more extensive necrosis, right? And third, you can see the ulcer will have a dry skin and a dead tissue. This is an ulcer seen in diabetes patients. So I can say this, a diabetic ulcer. And sometimes whenever you are lying in the bed, for example, a patient who is hospitalized, a person who is having a paraplegia of limbs, he cannot walk, so he's just lying in the bed. Sometimes what he can develop bed sore. Also we call this pressure sore. You call this a pressure sore or bed sore. Pressure sore or bed sore. Pressure sore or bed sore. Right? Pressure sore and bed sore. So if you see, this is the histological appearance you can see in a patient who is having a diabetic ulcer, right? So basically these are just the changes. You can see the granulation tissue. You can see a lot of granulation tissue in a patient who is having a diabetic ulcers. Okay, then we have two factors. Understand this. This is in front of you. That is your. You can see there are two things. We call this a hypertrophic scar. You can see the regular border and regular margin. So this is called as an hypertrophic scar. If I compare to this with excessive healing, you can see irregular border and a dense collagen deposition. We call this a keloid. So just by looking at the site, don't confuse. Keloid can occur anywhere. Hypertrophic scar will occur only at the site of scar. right? This will be keloid and hypertrophic scar, right? So if you see this keloid histology, this is your histology. You can see in the keloid, you can see a thick connective tissue. You can see a thick connective tissue. This is a histology of your keloid, histopaths of keloid. You will notice a thick or dense connective tissue. Thick or dense connective tissue. Then understand this. This is the image. We call this. This is your amyloid, and this amyloid is stained by a stain called as Congo red. And you can see, notice here, we call it an apple green by references. This is your apple green by references for amyloid. Am I clear? So just in this image, I want to show you something that you can see here. You can see here the necrosis here in this slide. You can see the necrosis in this area, which I am highlighting. This is the area of necrosis. This necrosis you can see in the periphery. Center is intact. So this type of granuloma we call this non-caseating. Non-caseating, where center is intact. Or this necrosis is caseating, but granuloma is non-caseating. But if you notice here you will see the necrosis in the center. So this is called as your caseating. So understand this. Caseating means this is seen in your TB patient. So TB means there will be necrosis where in the center. There will be necrosis where in the center. There will be necrosis where in the center. Okay, then you can see this is an image of angioedema. You can see the edema in this area. We call this an hereditary angioedema. Then you can see the granulation tissue slide once again. You can see a lot of granules. You can see a lot of granules. And this is the slide of myocardium, which is scarred because of MI. Then again, the difference between, you can see this is, just tell me the answer what it is. Keloid or scar, this is hypertrophic scar. And here you can see this is your keloid. This is your keloid. This is your keloid. Okay, then let me discuss about some of the images. So this is just understand this. It is mainly involving your circulants. There is a more chloride secretion. You can see patient will develop sinusitis. There will be pseudomonas infection risk. There can be pancreas exocrine dysfunction, and sometimes there will be azoospermia. So this is a classical, you can see slide that is showing you all the features of a condition called as cystic fibrosis or salty baby syndrome. Cystic fibrosis or salty baby syndrome. So just understand this. You can see this is X and Y chromosome. So this is nothing. It's a karyotype of a normal person. Normal male or female? XY, XY. So it is a normal male. You can see a karyotype of a normal male. Okay, if I move forward, you can see these are the features. These are the features. So let me highlight the feature once again. Epicanthic fold. You will see a simian palm crease. This simian palm crease means heartbreak line, which is just a straight line. A transverse lines in the palm. Transverse line in the palm. You can see mental retardation. Patient may also have risk of leukemia. The most common leukemia will be ALL, right? And there will be gap between first and second toe. There will be congenital heart defect like ASD, VSD. There will be umbilical hernia, intestinal defect like there can be Hirschsprung disease, there can be duodenal atresia. So these are all features suggestive of Down syndrome. We know the chromosome number, it is a trisomy at chromosome 21. So remember D for drinking age, D for Down. Drinking age means daru pine ki age. Drinking age is 21. If I say the next feature, you can see micrognathia, low set ears, overlapping fingers. You can see overlapping fingers means finger will overlap with each other, right? These are prominent occiput. So these are classical features. These are classical features you will see. Understand this. And the last thing is you will see here rocker bottom foot. So these are features suggestive of Edwards syndrome. E for Edward, E for 18. So it is a trisomy 18. So just I am writing 18. Or remember E for Edward, E for election age. So election age means vote dalne ki age. Voting age is election age 18. Rocker bottom foot, along with this you will notice polydactyly. Just pay attention. In the previous image I told you, see once again, overlapping finger means if you count the finger, let me do the 1, 2, 3, 4, 5. Fingers are 5. If you count here, you will see fingers are 6 or 7 or even more. We call this polydactyly. Then you can see cleft lip and cleft palate. You can see cardiac defect. So these are features of Patau syndrome. So these are features of Patau syndrome. So P for Patau syndrome, this is due to trisomy 18. P for puberty age. Puberty age in India is 13. Puberty age generally is 13. Not in India, generally it is 13. Rocker bottom feet you can see in both the conditions. A short height, coarctation of aorta, cubitus valgus, streak ovaries or empty ovaries, so they will be infertile. There will be webbing of neck, widely spaced nipple, and a broad chest, and pigmented nevus. This type of chest is called a shielded chest. Shielded chest. So this is classically seen in a patient of Turner syndrome. This is classically seen in a patient of Turner syndrome. Then understand this. You can notice here. This is a person 1, 2, 3, 4, 5, 6. You can see a person who is having polydactyly. 1, 2, 3, 4, 5, 6, 6 fingers, and ultimately 2 are also overlapped. Then in this image you can see both cleft lip and palate. Right? You can see both cleft lip and palate. Now understand this. And third image you can see the patient is having anomaly or problem in the formation of the skull. Right? So there is a development malformation that is affecting the brain. So we can call this a partial anencephaly-like picture. Then understand this. Some chromosomes and disorders which I'm talking about. This I already discussed. Family hypercholesterolemia. It's an autosomal dominant condition due to LDL receptor mutation. Marfan syndrome is here you will see fibrillin mutation. Ehlers-Danlos, you will see collagen mutation. Hereditary spherocytosis due to mainly anchorin. It can occur due to war, but mainly anchorin. Neurofibromatosis due to neurofibromin. Adult polycystic kidney disease due to polycystin 1. Cystic fibrosis, CFTR, cystic fibrosis transmembrane regulator. Phenylketonuria, phenylalanine hydroxylase deficiency, Texas disease, hexosaminidase B deficiency, SCID, we call it SCID, adenosine deaminase deficiency, alpha thalassemia, thalassemia, sickle cell anemia. These are due to hemoglobin defect. Then remember, this is Fragile X syndrome due to FMRP gene defect, Duchenne and Baker muscular dystrophy due to defect in dystrophin, hemophilia, factor VIII disorders. Then you can see again, this is a slide of, you can see the patient can develop deficiency of phenylalanine hydroxylase. So this is a patient can develop phenylketonuria. So I have just discussed this image once again. So just I want you to write this image so that you can get an idea what type of question they ask in genetics. Generally, they are the question based on these image-based findings. Then pedigree analysis. So you can see just pedigree analysis from your revise. You can revise from your notes or some from, well, if I get the time, then I'll make a separate video on pedigree analysis. So just you can see here 2x, no other changes. So this is a normal female. Now in this slide, you can notice here something, that is, you can see here the patient can have X and Y, 1X, 1Y. This is again a normal male. You can see here 1Y is missing, so this is a Turner syndrome. You can see the patient will have amenorrhea. Then you can notice here, XXY, Klinefelter syndrome. XXY will be Klinefelter syndrome. So these are the questions that they ask related to genetics topic. So now we'll discuss the last part of this so that I can show you some of the more images. So then I want you to revise this image before your exam. Okay, so just let us see once again. This is, you can see a mixed tumor of parotid gland. This is nothing. You can see a tumor of parotid gland. So just remember the fact, the most common benign tumor of parotid gland will be pleomorphic adenoma. The second tumor that you should remember for parotid gland will be, the most common malignant tumor will be mucoepidermoid carcinoma. And one more tumor you can see, that is a Warthin's tumor. Okay, then understand this. You can see this is a well-differentiated tumor. So understand this. This is a well-differentiated tumor that is having a similar feature like is normal cells, like a normal squamous cells, epithelial cells. You will see similar feature. If you compare, this is your pleomorphic malignant tumor. To understand this, here you will see there is a significant variation in size, and you can see there's a hyperchromatic nuclei and some giant cells. So this is a pleomorphic malignant tumor. You can see here anaplastic cells. So understand this, anaplastic cells. What are the features you will see? You will see here. You can see the cell nucleus size will become almost similar to the cells. You can see nucleus will be equal to cell, almost equal. Right? Then you can see this is an image that you can a tan colored. You can see we call this a fibroadenoma of breast. Fibroadenoma of breast. Right? So this is a microscopy view of fibroadenoma. Right? Microscopy view of fibroadenoma. If you notice this is a cut section of invasive ductal carcinoma of breast. It's an invasive ductal carcinoma of breast. You can see when you palpate this, it will be a stony hard in palpation. It is an invasive ductal carcinoma. We call this IDC. Now you can see these are cells, liver, histology of liver. You can see the metastasis in the liver. So these are, you can see these all are what? Metastasis, multiple metastasis in the liver. Multiple metastasis in the liver. Then remember these are total 10 hallmarks of cancer. Out of this, the 8 are significant and 2 are emerging hallmarks. So these are hallmarks of cancer. These are hallmarks of cancer. Okay, then if I want to show you, you can see this. The patient, you can see Papa Nicolai staining from a cervix. So this is a normal pap smear. It is a normal pap smear. And whenever any person who is having dysplasia or anaplasia, right? So you can see this abnormal pap smear. This is your abnormal pap smear. In abnormal pap smear, you will see what? You will see these malignant cells, right? They will have a hyperchromatic nuclei, right? Hyperchromatic nuclei. Then understand this, we are having a BRAF gene. This BRAF gene is associated with many mutations. BRAF is linked to hairy cell leukemia. It can be a cause of Langerhans cell histiocytosis, melanoma, papillary thyroid carcinoma. So this BRAF gene is diverse, and they can ask you the question that is BRAF is having a role. This question already being asked, it's having a role in hairy cell leukemia. Hairy cell leukemia. Then you can see this is, you can see seeding of omentum by a carcinoma. We call this omentum caking. It looked like a cake, so we call this omental caking. We call this a transcoelomic spread. Transcoelomic spread. So this is how we differentiate. You can see this is called a well-differentiated tumor. Right? Well differentiated, and if you compare this compared to this, poor differentiated. It's a malignant tumor. It is a malignant tumor. So this way we'll conclude the session. So I'll make a separate session of systemic pathology images. So we'll see you in the next video. Thank you so much. Bye bye.